Dr. Katherine Labiner. I know her professionally and personally, and she is top-notch. She's an epileptologist out of Boston with Neurology Consultants of Boston. And as you can see, not only does she have a passion for the epilepsy community, but she also has a passion for her four-legged fur babies, too. You saw her screensaver. So you all are in for a big treat. I had the opportunity to hear her last year. She's amazing. And without further ado, Dr. Katherine Labiner.
Hello, everybody. Can everyone hear me? Sweet. So I don't have to use the microphones, which is like my least favorite thing to do. So this is intended to also be a bilingual presentation. So if you have questions in either English or Spanish, just go ahead, raise your hand, ask questions in the middle, and I'm happy to translate anything. The slides are all in English, but we do have them available in Spanish as well. So you just let us know, and we're happy to do either way, both ways, intermix. I'm good any way you guys are. So what we're going to do is just start with an introduction to epilepsy. Well, if my slides work. There we go. So we're just going to go through a couple different ideas today of really what is epilepsy, what are the different seizure types. I think we all get to see on television those very classic, I always call them in the office, the as seen on TV seizures, right? The big convulsive events that look very exciting and dramatic. But the reality is for a lot of our patients, that's not what they're having. They're having all sorts of variety of seizure types. And because of that, it's really important to be able to have these resources to show patients, parents, and also especially the schools. I'm a pediatric neurologist in training, and so because of that, then we deal a lot with the school systems and what the schools are doing. And I think a lot of the teachers don't always know what to look for. They don't know what they're supposed to do, and they can miss it if we don't know what we're looking for. So we're going to do that. We'll review seizure first aid really briefly as well, and then also how we use EEGs and what we do with our EEGs, and kind of what I'm looking for not only as a neurologist, but then when we use all that lingo and talk to families about what it says and what we saw, really what we mean by that. Because I know we send you guys reports if your places are anything like mine. We send you a report online, and then hopefully somebody explains it to you. But I know that that doesn't always happen, or it may not happen for a couple months. Thank you. Or it may not happen for a couple months. And so because of that, then you don't actually know exactly what it says or exactly what it means. So we're going to do all of those things in the next hour. So what is a seizure? This at its most basic is really how the brain controls body and movements. Every single one of our neurons talks to each other through electrical activity. So just like when we monitor the heart and that's working through electrical activity, the brain is working the same way. All of the neurons are working that way. So the brain is then sending signals through the nerves to the muscles all over the body. The muscles then are also sending information back to the brain. And this is all done very, when we say split second, we are talking fractions of seconds that this is taking for that information to travel. The problem for epilepsy is that the seizures are really these abnormal bursts of electrical activity that are interfering with the normal signal that is trying to get through. So the brain is actually changing then the way that the body functions during this. This is why seizures all look different, because depending on where the seizure originates from, depending on what part of the brain is involved, which muscles are being affected, that's all going to then change what the seizure looks like. It's also going to change whether or not the person is responsive or unresponsive. And that's really, really important because you may have someone who looks responsive, but they may not actually know what they're saying or remember what they've said during the seizure. And so that's really important for us to think about as well. And because of that, then you're going to see a variety of different types of movements, different types of responses, and they can last anywhere from seconds to minutes, and in worst case scenarios, closer to an hour or even longer. A majority of seizures are going to stop on their own in less than 5 minutes. That's why we use that 5-minute mark for using the emergency medicines at home. But every single kid is going to be different. And so because of that, then we often respond to those things differently. So what is epilepsy? There's two big definitions for epilepsy because you get to it in one of two ways. One example is someone who has had 2 seizures separated in space and time. And the reason that that's important is because 2 seizures in 24 hours aren't quite separated enough for us to say that that's clearly a problem, because they could be provoked. That's another key word in the definition for epilepsy, is it needs to be unprovoked, meaning we don't count people who have diabetes, for example, and have changes in their blood glucoses and then lead to seizures. We don't count them as epileptic, right? That's a provoked seizure. They had that because the blood glucose changed. So they're in a little bit different category. Now, infection is kind of its own category because we know infections in the brain can cause seizures, and you may say, well, you had an infection that led to the seizures, and you may not be at risk for having them past that infection. That's going to be in a little different category than epilepsy as well. The other way that the diagnosis is reached is if you have had a clinical seizure in addition to then a risk of recurrence on your EEG. We'll talk about what we're looking for on those EEGs in just a minute, but really the key is if your EEG is normal, that doesn't tell me that you have a risk for having another one. So if you've had one seizure and an EEG that tells me you're at high risk for having another seizure, we're gonna go ahead and call that epilepsy too, because we know the chance of you having a recurrent seizure is gonna be significantly higher than the 30% chance that you have kind of out in the world. You'll hear some common terms thrown around by epileptologists too. Aura probably being the most frequent one that you hear us talk about. We'll often ask our patients, do you have an aura? Well, sometimes I think we forget to define what that means. That is any sense that someone has that the seizure is coming. It can be a smell, it can be like a visual change, it can be something that they hear, or even some people say, especially for us and with our little kids, they'll tell us, I don't really know, but I know it's coming. And they can't quite tell you what it is that happens beforehand, but they know something is about to happen. And that is also considered an aura. When they tend to get older, we will often hear that really what they had was this like sense. Some kids will describe a sense of doom. Some kids will describe a sense of that like they felt that feeling before. Deja vu is a very, very common one, or a dream-like state where they kind of know what's happening, but not exactly. And those are all auras. The auras are really the start of the seizure in the sensory part of the brain. And so that's why it's really important for us to know, because it can then help us know where the seizure may be coming from. You'll hear ictal and interictal. Interictal is a fancy word for between seizures. Ictal is a fancy word for during a seizure. So when we talk about interictal or post-ictal, after a seizure, we're really talking about those time periods of what's happening in between, during, and then right after a seizure. Discharges we'll talk about more when we talk about the EEGs, but really those are just going to be any epileptiform discharge that says that I'm at risk for having more seizures. That's those little sparks of abnormal electricity that tell us that there is a potential to have an epileptic event. There we go. So generalized versus focal is really the first breakdown of where we talk about the seizures. Generalized is going to be whole brain involved all at one time. So that is from the moment that the seizure starts, the whole brain is involved. These are people who are not going to retain consciousness during it because both sides of the brain are involved. So neither one of their memory regions is working. For focal onset seizures, these are going to be areas of the brain where one part of the brain is involved. Now that can spread to involve the whole brain, and that's called secondary generalization, meaning that it started in one area, and then because the seizure continued, it actually spread through the rest. Now, sometimes on an EEG, where you may have been told you have focal seizures, but now we have the EEG on you and we know exactly what we're looking at, you may hear that we actually think you start in one area and then spread very quickly. This is classic for frontal lobe epilepsy, and it's called rapid bilateral synchrony. And what that means, literally, the two hemispheres in the frontal lobe are so interconnected that they talk to each other in split seconds. So physically, we don't see any difference. But when we can do the imaging and the testing on the brain itself, then we do see that there's that split second that it starts in one area before it spreads to the other. I think the other thing to remember in all of this when we're talking about this is that seizures are going to look a bunch of different ways. Even when we talk about generalized seizures, right? These are all technically seizures that are all brain involved all at one time. Anytime you have a generalized discharge on an EEG, you have the potential for any one of these seizure types. And so that's why sometimes we'll tell you, I don't know what it's going to look like, or I can't tell you what that seizure is going to look like. Because for me, when I see a generalized discharge, you could have a tonic-clonic, you could have an absence, you could have a myoclonic. Atonic are the least common of all the seizure types, and those are the ones where they just fall. We're going to go through examples of each one of these, but kind of the base is that the GTCs, or the generalized tonic-clonics, those are the ones that used to be called grand mal seizures. Those are the big, as seen on TV, sudden loss of consciousness, arms and legs are going to stiffen and then start to jerk like this. Absence are most common in our elementary school age kids. We see them in all age groups, but that's often when they start. And we'll go through that one as well. But what happens for those kids is they pause, and then they keep going like nothing happened. It's very obvious for people who are talking to them. You may not notice if they're sitting and watching TV. You may have no idea. A lot of our older kids will tell us that they know they missed something. And so they actually become more aware of their own seizures because they recognize people moved in a room, or they're behind in the lecture in class where their teacher told them to open a book and they don't actually know which book they were supposed to get out yet. Those are very, very common things that we'll hear from our elementary school age kids. It is very frequently, especially in the kindergarten and first grade age group, to be diagnosed as ADHD. The teachers are going to tell you they're not paying attention in class. And so one of the things that we always want to make sure is then they get on ADHD meds and nothing got better. The next question should always be, are we sure they're not having seizures? Because if they are, the easiest thing for us to do, treat the absence epilepsy. And I have kids who have doubled their grades, and all we did was treat their epilepsy. Atonic, quick, rapid fall to the ground. This looks different than for people who pass out. Typically, when we think about syncope, which is the fancy word for passing out, we see people who are going to just kind of stiff board on over. These are kids who are just falling straight down. It's literally like ragdoll. All of a sudden, they're on the ground. Like I said, very, very rare type of epilepsy, but absolutely one we see. This is very, very common for us to see in the Lennox-Gastaut patients. So they will have the atonic seizures where they're so fast that they actually only drop with their heads and then they're right back up. And that's because the rest of the body didn't get the message yet because it was so fast that only the upper body was involved. Myoclonics are going to be those quick jerks that you'll see, lots of very, very classic for juvenile myoclonic epilepsy, which is why I got that name. Very, very common to happen in the morning. So kids will tell you, I woke up in the morning and I have all these jerks, or I can't brush my teeth because I can't hold on to my toothbrush. Often by the time we see the kid, it's because they finally had a generalized convulsion. And then you ask them, hey, do you ever have jerking in the morning when you get up? And I've had a couple of kids, I had one kid who looked at me and goes, how do you know that? I said, because I recognize the storyline, right? And so for us, that's a very important question. When are you getting your seizures? Because that can also tell us what type of seizure it may be. Tonics are going to be the ones where they stiffen. These may look kind of focal because people may turn during them and things like that, but it doesn't mean that it's not a generalized seizure. But what it can tell us is if you always turn one direction during your tonic seizures, that can be an indicator for us that maybe one side of the brain is driving it more than the other. So we have a couple of examples. So the first one is going to be a generalized seizure. So you can see here, whole body is involved, both sides, legs and arms. They're supporting the child because the child cannot actually control their own head. They're doing some beautiful seizure first aid by not letting them hit their head on the wheelchair. Vocalization is very, very common. What they're doing right now is actually called figure of four.
Look at this angel. Look at this angel. Isn't he the good?
So kind of the classic things that you'll see. This one goes on for a total of 2 minutes, so I won't make you watch a whole 2-minute seizure. Well, if I can stop it. Maybe not. Okay, we'll go to the next one, then I won't click play. So what you saw in that one, whole body involved all at one time, right? From the moment it started, both sides, legs and arms, head, face. What you did see as it progressed was one side was very much clearly involved compared to the other. And that is often common. When they did that figure of four, or the fencing posture, you'll hear it called sometimes, then what that really tells us is that one side is driving that more than the other. But that can just be where the seizure settled. So it's still generalized, but one side is really pushing out more of the abnormal discharges than the others. This is going to be an absent seizure. So this is the one elementary school age kids told they're not paying attention in class. Oftentimes teachers are the first ones to pick this one up.
Tyler.
So that is a beautiful example of an absence seizure. So what was the immediate thing he did when he stopped seizing? He started blowing again. For him, nothing actually changed. The only thing that changed was for us. You're watching him, he paused. He kind of lost some facial expression. You saw the lips move. That's a very common thing. They're called automatisms. So you can have movements of the lips, movements of the hands, and those are very, very normal. And we tend to think of them as purposeful movement that's inappropriate in the situation. So like for that, right, we're doing our lips together. That can look like a purposeful movement, but it didn't make sense given what he was doing, right? You'll see people mess like they're doing a button or undoing or doing a button, but yet they don't have buttons on their shirt. Right? It's not a purposeful movement given the situation. Wiping your hands on your legs is also a really common one that we'll see. And again, it doesn't quite make sense because they were just hyperventilating. This is a great example, and it's actually for those of you who have had EEGs, the reason that we ask you to hyperventilate in the office is exactly for this reason. We know that we can trigger the seizure with hyperventilation. And so because of that, we are intentionally trying to see, can we get one in the office? Same reason we flash the lights at people during EEGs. We're trying to see, can we trigger photic epilepsy, which is actually really rare too. So this is going to be one of the drop seizures.
Maybe something in the cupboard you can use.
Can wear those with shorts again then?
Andy? Andy? Andy, you okay? Yeah.
So is it going to be okay?
So very, very classic atonic seizure. You'll often see the atonic as part of what we call the spasms, infantile spasms if the kid is young, epileptic spasms if the kids are older, even though they look almost identical. When you look at them clinically, it has to do with the age which they start or the age of the patient, because obviously if they have infantile spasms that start when they're an infant, but now they're 15, 16, we don't want to call them an infantile spasm anymore because the kid's much bigger. So you hear us call them atonic or epileptic spasms. It's that quick drop down. And so you can see, unlike when kids pass out, right, and they kind of drift off to the side, that is very fast right down. Often the kids that you are seeing who are wearing helmets, it's for exactly that reason. They are so prone to hitting their faces on things, whether it be the front of their wheelchair, a table, anything like that, that we have to protect their head and protect their teeth. So you put the helmet there so that they'll hit that first and protect them. All right, this is myoclonic seizures. So that quick movement of the arms. As you can see in this, both arms are involved. That's classic for the myoclonic seizures, whether it be both arms or both legs. It's all involved. So with the myoclonic seizures, arms are the most often ones that are involved. And so that's usually the one that bothers people. The legs get involved and people will fall. So they'll tell you like, oh, I'm clumsy in the morning, or it takes me a while to get going. We hear that a lot from our kids who have myoclonus in the legs. And the reason that is because they go to get up in the morning and they have the myoclonus, so they fall a lot in the morning. And then because of that, then they are at risk for having the generalized convulsions. Oftentimes in the juvenile myoclonic epilepsies, you'll see that the kids will tell us like, oh yeah, I've been having those jerks for a while. They start to get longer and longer and cluster, just like they did in that video, right? Where you saw one after another. I mean, we only watched 10 seconds of that video, and I think in the 10 seconds, the girl probably had a dozen, if not more, seizures, right? Split seconds, just going like this, and they'll often come in groups, stop for a second, come again, and they always look exactly the same. And that can help us differentiate tics versus myoclonic seizures. That's a very common question that comes to us in the office. How do I know? Tics are often going to involve only one side. Myoclonic seizures are going to involve both. Myoclonic seizures are rare to involve the face. Focal seizures are going to be more common, and you're going to get this motion. With the face, as opposed to pulling back on both, is a lot harder. And so most people don't get that grimacing type look. And if you think about the generalized tonic-clonic we saw, right, the face didn't look like it was pulled back. It's really they clench their jaws, and that's going to be more common. This is a tonic seizure, so you're going to see the stiffening that comes with that. Eyes are often rolled up and back. And so parents will tell us like, oh yeah, it was like they were looking way, way, way up. If they're looking to one side or the other, that can tell us where the seizure may be coming from.
Okay, Kelly. I'm just going to put you onto your side. It's going to be okay.
Just so you know, we got these videos from the British
Just
school
lie down
system.
and rest.
If you're wondering why everybody has British accents in them. Very, very common that you're going to see the extension in the arms and the legs. The key, and actually the interesting thing in that example out of all of them, is that they rolled them on their side and bent their knees. Most of the time what's going to happen is this kid is going to be so stiff that when you try to roll them, they're still super, super stiff. You have to protect those kids a lot because they're prone to then arching their backs a little bit when they do it. And because of that, then they can hit their heads on things behind them. So when you're talking about the seizure first aid for those kids, you want to make sure that we're protecting them in that way and protecting their head kind of from all directions and not just the one. These are also ones that you are going to have to be more active to help them stay up than some of the others because their body is so stiff that if you were to just try to roll them onto their sides, they may roll all the way forward. So you may have to brace them a little bit as well. I also always recommend figuring out which way you're stronger. So for me personally, I am stronger pushing someone, which means I'm better behind them than I am pulling somebody towards me. Pulling somebody towards you is a heck of a lot harder. The other thing then is if you pull them towards you, you now have to support them up. We'll talk about that a little bit more when we do seizure first aid in just a minute. But really, if you can then lean these patients back on you while you're kneeling, that puts them at an angle, but then also you don't have to maintain them during that time. Focal seizures can come in a whole variety. They can be motor, movements of one side of the body, like I was demonstrating with the face. You can get movements of just one arm, one leg. For people with what we call the very hemiclonic or hemitonic seizures, they can actually sometimes tell you that they're seizing. Like, oh yeah, I'm seizing right now, my arm is seizing. And it's because that is the only part of the brain that's involved. So they can be very, very aware. For little kids, they'll actually keep functioning exactly like they were, just without using that one arm. So they'll keep eating, they keep doing, they're playing, and yet that one arm is very, very involved. Sensory seizures can also occur. It'll be any sensory sensation in one part of the body. It can spread, and those are common to start in one area and then spread down the body. So we'll hear like, yeah, I got this numbness or even a burning sensation that then spreads down. Autonomic are probably one of the more rare ones that we see, but we absolutely do. And this you're going to see kind of blushing, increased heart rate, nausea. The classic for that is a syndrome called Paniatopoulos, which is a really, really, really long Greek word. But those are seizures that come from the back of the brain. They are classic to last hours in younger children. So you're talking like the 4 to 6 age range. And the kids will tell you they're dizzy, they vomit, and they're like pale but sweating the whole time. And then after the seizure's done, they pass out, but they are awake, alert, and can tell you exactly what's happening. They'll respond to their parents during them. They can take meds during them. So it's this very interesting thing that we'll see with that specific seizure type. And then what we call the psychic, we're trying to figure out a better word for this. We don't have it yet, but those are going to be deja vu, fear. Hallucinations are a really interesting one. What we don't tend to see is fully formed visual hallucinations. You can have visual changes, but we don't tend to hear people saying like, I saw a person in my room, or I saw someone who was then speaking to me. It tends to be shapes and colors that we hear more. Intractable epilepsy is epilepsy that is not responding to medication. It's uncontrolled, continues to happen despite multiple medications. Kind of the ballpark or benchmark for us is to say, if you have tried 3 or more medicines at good dosing, then that's considered intractable or refractory epilepsy. Occurs in about 1 of 3 epilepsy patients, which makes sense if we think about the way that the medicines work. We consider a good medication, or one that will go to the market, if it works in 30% of people. Well, that's really not that great if you think about it, right? But that's the best we can do. If you have to try a second one, the chance of it working is now in the mid-teens. By the time you go to the third one, the chance of it working is 6%. So the more we try, the less and less chance we get that it's actually going to help control the epilepsy, and the chance that you get to monotherapy is also less. They are also considered intractable if you have had a year worth of seizures on decent dosing and still also not being treated, so are being completely controlled at that point. So at that point, we do recommend that you go see an epileptologist. So I am epilepsy trained. I think actually all of the neurologists speaking here are epilepsy trained. So this is what we do specifically in neurology, is not just do we treat, in my case, pediatric neurology, but pediatric epilepsy. Epilepsy treatments come in a lot of different forms. We have the drugs. Those are probably the most common of all of them, right? This is the pills. You have a variety of them. I think we're up to 36 now, which is pretty good. We have epilepsy surgery. That's going to be more for the focal patients, although it is becoming more and more now that we're seeing that there can be improvements with generalized patients as well. Now, the problem for the generalized patients is that there's no one place typically for us to take out. And that's the key for the focal, is that we are doing focal resections where we are just taking out that one area. For the generalized patients, we do have vagus nerve stimulators. Those are devices that are implanted right here below the collarbone and actually run up the vagus nerve. It is not intracranial at all. It is all external. So while it is epilepsy surgery, it actually doesn't happen in the brain. It is completely down here in the neck and then in the chest. You can have other types of stimulators now. The deep brain stimulator is the most common one in the adult side, I would say, along with the RNS. The DBS right now is being tested for generalized epilepsy. The RNS is about to go through testing for generalized epilepsy as well. And what the RNS does is that's actually a responsive nerve stimulator, meaning that you have the strips. Just like when we do your EEG, you basically have an EEG sitting on top of your brain every second of every day reading your EEG. I then teach the device what to look for, and we say, this is exactly what you're supposed to see. This is what I want you to fire on. And then there's a depth electrode that actually will then fire on the specific area where the seizures are coming from. That is intracranial surgery, meaning within the skull and on the brain itself. There are also dietary treatments, and the ketogenic diet is probably the strictest of all of those. I personally use a lot of modified Atkins for my patients. The problem with the ketogenic diet is that it's not the one that most people are doing because they want to lose some weight and they're trying to build their muscles, because they're like, well, it was like my birthday and I decided to have a cupcake and that was totally fine. That is not true for our epilepsy kids. When they are on the ketogenic diet, it is incredibly strict. It is an exact ratio of carbs to fat and protein. And because of that, there is no such thing as a cheat day. I tried it once. We were supposed to do it for a day. We did it as a fundraiser for the Epilepsy Foundation, and the doctors at camp said, well, we'll eat it if people will pay to have us eat the ketogenic diet. I made it through lunch and I was done. I couldn't do it anymore because it was so much oil, so much fat. I literally, I felt so sick. And I just couldn't do it. I will say the biggest thing that people tend to miss on the ketogenic diet, even our kids, is fruits. Fruit is incredibly restricted. There's a lot of sugar in fruit. And so on an average day, most kids will be able to have 5 strawberry halves. So if you do the math on that, that's 2.5 strawberries in a day. Oh, and you're going to have that with heavy whipping cream because that's the only way to get the fat. Yeah, it's not fun. It's not easy. If you have a child who's G-tubed, changes the game completely, because there is a formula. We can put that through the G-tube, very, very easy. But if you have a child who is eating by mouth, and especially one who goes to school and who wants to function like a normal kid and not feel different, the ketogenic diet is unlikely to be the answer for you, which is when I use modified Atkins. Seizure first aid, there are lots of different versions of this slide. The key really in all of this is to protect the person who's having the seizure, right? It's to protect them from getting hurt during it, but then also to make sure that we are supporting them through it as well. You want to stay with them as much as you can. Now, the caveat to that is that sometimes you are by yourself. Now, luckily, we all carry cell phones now, so it's not as big of a deal as it used to be. This used to be a really big problem when somebody had to go to a phone and then come back, right? This is less of an issue now, but if you are by yourself, we actually recommend staying until the end of the seizure and then going to call EMS, or if you get a point where they are stable enough when you can leave to go get the phone, that's when you want to do it. You're going to protect their head, put them on their side, and the reason you want them on their side is to make sure that if they were to have lots of drool or vomit during the seizure, it's just going to come out, because now they're on their side and it's just going to drool or come out of their mouth. So then I will say in almost every single convulsive event I've seen, the very first thing that every single person does is goes right when it's done. If you're on your back and that vomit is sitting right in your throat, it now has a straight shot into your lungs, and that's how we get pneumonia. So we do not want to do that. You never want to restrain a person with epilepsy. They will be stronger than you, and you will likely hurt yourself and them during it. So all you want to do is protect them during the seizure. You also do not want to put anything in their mouths. I will promise you, and we can all try it right now. Try and relax your tongue as much as you can in your mouth. And then try and flop it backwards. You can't. The reason that is because our tongues are actually all connected down here too. It cannot flop back and cover your airway. What it can do is get in the way, absolutely. But really the thought behind what people were hearing when they were worried that the tongue was coming backwards and flopping was probably more saliva, vomit, something like that was in the throat that was obstructing, not the tongue. So we do not recommend putting anything in your mouth because I have seen broken teeth. I had a kid who chomped down on their dad's finger and broke the dad's finger during it. And so somebody ends up hurt when we put things in the mouth. In terms of seizure precautions, this is a lot of also seizure prevention. Keeping a regular sleep cycle, we know that lack of sleep is a huge trigger for seizures. That's probably one of the most common triggers in my adolescent patients. Taking your medications consistently, and then there's a key phrase there, as prescribed. Right? I have plenty of patients who are taking it consistently, but it may or may not be exactly the way I wanted them to. And that absolutely, if you are having side effects and trying to cut down on something, let your doctor know because we will help you. Because there may be a better option for you, an extended release option. If you're struggling to remember taking it multiple times a day, that's when you need to talk to your doctor to help to make sure that it's a good regimen for you. Children are at an increased risk, and it's interesting, we always talk about children as the ones who get sick. Adults are also at an increased risk when we're sick. We just tend to not get sick as often as kids do. I will tell you, as a pediatric neurologist, I spend a lot of time with a cold because I get to see all the sick kids. So what we want to do is really protect them. Some people have special regimens that they'll do when they're sick, and that's to help protect them from seizures during that time period. We always encourage physical activity. There is nothing that someone with epilepsy cannot do because they have epilepsy. The key is about doing it safely. You can absolutely swim. You can absolutely rock climb. Okay, I do take that back. I don't like free climbing, but I don't like free climbing for anyone because I think it's silly. I don't understand why you would want to climb up a rock and not have protection. So we do some of those. Wearing a helmet while you ride a bike, always a good thing. Wear a helmet while you're horseback riding. But you are absolutely allowed to do those things. When you're swimming, you want someone in the water with you. Not just watching, but in the water with you. And that's because in those absence seizures, like the one that we saw, you can imagine it doesn't take very long for that to happen and for you to not realize. Know the driving laws in your state. You have to know each state is different. There are going to be mandatory reporting states and non-mandatory reporting states. I currently am in practice in Texas. We are not a mandatory reporting state, which means it is my job to tell my patients what the law is, and beyond that, it is not anything else I have to do. Other states mandate that the physicians have to report all of their epilepsy patients and if they're having breakthrough seizures. So it depends on where you are and kind of what the laws are in your area. They range anywhere from 3 months of no driving to a year and a half at the longest. You can imagine a year and a half is a really, really long time. Most of us will say 3 to 6 months is about what you need. We talked about water safety. We talked about unprotected heights. And then power tools is a funny one because, again, I don't really want any of my children using a chainsaw, and so I'm really not against it when we're like, yeah, don't do that. However, we recognize that some adults do, right? We had a very, very bad storm in Texas, and somebody's got to go cut up the trees. This is not the time, if you do not have controlled epilepsy, to learn how to use exciting things. Status epilepticus is another term that we use a lot. It is a seizure defined as a seizure lasting 5 minutes or longer, or 2 or more seizures that have clustered without return to your baseline. And then that is often going to require a rescue medication, or if it continues, it's considered a medical emergency and the one time that we do recommend that people go to the hospital. There are lots of rescue medications available these days. These are just a couple of them. Probably the most common ones we're using in our practice now is the intranasals. It's a lot better than a rectal gel. For anyone who's tried to give that, it's impossible. It is so hard, it is so messy, it's horrible for everybody involved. The nasal sprays are nice. The schools really like them because all you need is access to their face. The one thing for some people is if you do have a really, really small nasal passage, then this may not be the best option for you, just if it can't fit. So with some of our genetic conditions, they actually don't respond well to them because they can't fit to get adequate delivery of the medication. In terms of timing, they're both quite quick. And so that's really, we're going for highly vascularized areas. They're going to be able to absorb the medicine very, very quickly. It's not immediate, but quick. We usually mean within 30 to 90 seconds for most of them. When we talk about the EEG, this is the most important thing for us because it allows me to see exactly what's happening in your brain every second. Whether it be during a seizure or not, we can learn a lot of information from an EEG. Ideally, we want to capture an event because we can tell you exactly what it looks like on your EEG, where it's starting, where it's going to. There are lots of different ones that you may see and be offered. The routine ones are going to be the 30 to 45 minute ones that are done in the office. An ambulatory is where you get hooked up and then take it home with you. There's no video involved, nothing like that. You're just wearing it with a little backpack. The in-home video EEGs are going to be the same idea, but they come to your house and put a video. The reason that we like videos, especially for people who sleep in a bedroom by themselves, is that then if you have a seizure, I can tell you what it looks like. If you don't have a video there, I don't know what it looks like. I can tell you, yeah, you had a seizure at 2 a.m., but you can imagine if you live by yourself, no one may know what that looked like or be able to describe it to us, let alone to know. This is really, really helpful for older kids because I can tell the parents I know what's going on at night, even when they don't, and that we see gives a lot of independence for our kids, our older kids, to allow them to go back to their own rooms or to allow the parents to go back to their bedroom so that they don't feel the necessity to be with the kid all the time. And then we have the epilepsy monitoring unit, which is where you are admitted into the hospital for that. It's going to be, again, video EEG, and then you have a tech who's actually watching your EEG every second while you're in the hospital. And so they're going to alert just like your parents would if you were at home. But that way, too, sometimes if parents don't notice it, we still get to see it because the techs will alert as well. We also have non-epileptic events, and this is why EEGs are so important. I have seen seizures that I would have sworn were not epileptic that were, and vice versa. Ones that I was like, oh, I'm pretty sure that's going to be epilepsy, and we get the EEG on, and you're like, nope, that wasn't it. And that's why it is so, so, so important for the EEGs to capture an event. We used to think of them as kind of this purposeful thing, but what they've actually found is a lot of patients have no control over what they're doing. It was initially studied in women and really thought to be a problem of women in their 20s who had been assaulted. This was kind of the classic. Well, interestingly enough, the best data now comes out of the military in men with PTSD. And so what we know is that any time that there's trauma involved, absolutely a trigger for non-epileptic events. And then also we know that we see them as a comorbid condition in epilepsy. Very, very common for people to have both, and making sure that the people around them know the difference between them is really important because we want to treat the epileptic events, but we don't have to treat the non-epileptic events in the same way. Now, you still have to protect them. You're still not allowed to drive, but it's not going to be the medication path that we normally take. There are now seizure detection watches and other things. I personally like Seize Alarm. That's one that matches all of it. We have the Apple Watch on here, but they actually have it for the Samsung watches, all of those. Those are all available now. It is an app. It uses the Fitbit technology, actually, so does the Embrace watch. And what it does is it's looking for repetitive movement. You have other devices, and depending on which ones, I will say some of the ones that we see are not as good. This one tends to be pretty good. The mattress devices I tend to find go off a lot without a lot of assistance. And so if a kid moves a lot at night, it may not be the right one for you. My favorite seizure detection of all time is old school. It's a baby monitor. I am a huge fan of a baby monitor in somebody's bedroom if they have epilepsy. We actually use it on our young adult retreat so that the kids can stay in a room by themselves, and that's okay. And I have a baby monitor that's in their room, so I hear it if something happens. We also recommend seizure tracking. There are lots of different devices to use that are downloadable on your phone. I'm a fan of Nile, which is a newer one that has come out recently because you can add multiple caretakers to it. So both parents can be on it, the kid can be on it, the school nurse can be on it. Lots of different people can see all and be all adding to the same thing, as opposed to us having to pull up 3 different devices and try to merge them in my head. There are also seizure dogs. I think somebody spoke about that earlier. I will say most of our dogs are going to be seizure response dogs. Seizure alert dogs are really there to alert someone else that you are seizing. And so most of them are going to be a combination of the two. Sometimes we do get dogs who absolutely can alert, especially if it's an aura you're not very aware of. They may notice something before you do. I will say, I tend to find that the dogs are just as good as the parents in that sense, that parents will tell us, and I've had many parents hit that button and I'm like, what did you see? And they saw something that we didn't see until we started to see more and more of the seizures, and we get to see the change too. They are specifically trained to help someone during a seizure. They're often trained to roll you on your side and then sit behind you and lay down to keep you from rolling back over. And that's really what we want them to do, to help protect you. Some of them are also trained to alert. If you have a VNS, you can actually activate the VNS. I have one patient who has a dog who is trained to swipe their magnet for them. So the dog can do that too. It just depends on the situation. They are not cheap. I would say the average is 15 is probably a conservative estimate. Most of them are in the $25,000 to $60,000 range per dog. And they're good, and they have to be older, and they have to be bigger dogs. That's the other thing, is we'll have people come and be like, can we train our Yorkie? And it's like, I'm gonna have a real hard time getting a Yorkie to roll somebody over. And so they do have to be bigger dogs. So you're looking at the Doodles, the Golden Retrievers, the Labradors. They tend to be big dogs. Sudden unexplained death or unexpected death in epilepsy is death in a person with epilepsy without any other known cause. So these are going to be people that clearly didn't have an injury, that they didn't drown. Drowning is not considered a sudden unexpected death. That's drowning secondary to a seizure, so it's a little bit different. It occurs in very, very, very few people. We are talking 0.1% of individuals with epilepsy. It is more common in adults than children. And really, when we talk about those triggers, I think it makes more sense that it's more common in adults than children, right? Children tend to be pretty good about going to bed. They also have parents to make sure that they're taking their medicines. The most at-risk population is young adults. Most cases occur immediately after a seizure or during, and are thought to be secondary to breathing changes as well as heart rhythm changes. We know that people who are at risk for prolonged seizures in sleep are at the highest risk. We talked a bit about the risk factors. Generalized convulsions in sleep, probably number one. Noncompliance with medicine is a huge issue. So I recommend to all of my kids, especially my kids going to college, I tell all of them, I'm not naive enough to think you're not going to go out. I'm not naive enough to think you're not going to party, and you're not going to do the things that I would like you not to do, like drink, which can lower your seizure threshold. But what I will ask you to do is to make sure you take your meds before you go out. And that is how we help protect ourselves from this, because I want them to have the same experience as everybody else, but I want them to do it safely. And that's how we do that. We also think of this, I think, sometimes as only the person who's affected, but it's really not. This is a family change that happens, and it affects every single set of parents and every single sibling in that family. I will say we've done a lot of sibling groups, and the number one thing that I hear siblings talk about is that they're afraid that their sibling is going to have a seizure at school. They're worried about what other kids are going to think. They're worried about what other people are going to say. And that, I think, is so interesting, because it's the same fear that the kid with epilepsy has. I'm going to have one. What are people going to say? But their siblings worry about this for them too. Parents worry about sending them to school. What if someone doesn't notice if my kid's having seizures? What if my kid gets hurt and nobody notices, right? What if they're out somewhere and something terrible happens and nobody knows what to do? In epilepsy, in Texas, we have a law called Sammy's Law, which actually mandates that all teachers have to be seizure first aid trained. And so they do that at the beginning of every single year. There are also behavioral concerns. Lots of kids are super anxious, especially if they've had a seizure at school. They don't want to go back, and I don't blame them, right? They're worried about all of the social aspects of it, but also too, if you think about the fact that for a lot of kids with generalized compulsions, they may have urinary incontinence, that is not something as well, we'll say well taken by other middle schoolers, for example, right? So we want to make sure that we're protecting them in that way too. There's lots of caregiver support, and it may not be in all of the ways that we think of it. I also like to get my kids meeting other kids with epilepsy. It constantly amazes me how many families I say here, and they'll say, oh, nobody else in our school has epilepsy. I'm like, that's nonsense. I can name another kid in your school who has epilepsy. I know that that's not true, right? And so it's really important, I think, to support the whole family through this, because it is not just the one person or their parents. It is literally everyone in their family, including their grandparents. Their grandparents may be scared to watch the kid now, right? They don't know what to do. And we have family trainings. The Epilepsy Foundation in pretty much every state has family trainings that they will do, and there's lots of available things online as well. We have lots of resources here, lots of different places to go to look for these things. The Epilepsy Foundation and then the American Epilepsy Society have lots of stuff for families too. And most states have a camp for kids with epilepsy. In Texas, we divide it up by age, and it is one of my favorite things. So I encourage all families to get out there and to really kind of immerse yourself in it, because you are not fighting this alone. And it's easy for me to say because I get to see it 14 times a day, but other families don't. The parents do feel alone and kids feel alone, and I can tell them until my face is blue that they're not. But I think until we really get the families connected to other people, and that's why events like this are fantastic, then they do feel like they are by themselves. And you'll see tomorrow, if you go to Disneyland, that you are not alone in this at all. There are a bunch of us here with you. And that's all I got. Questions? All right, if anybody has any, I'll just be right up here and probably out there. If anybody has any questions, I'm happy to answer them.